Good morning. Happy Midwife Monday. Glad to be back. We missed the last 2 Mondays. Babies were being born and injuries were being dealt with. I'm in a brace. My cast is off, so that's super exciting. Okay, so today we are talking about babies' feeding habits, babies breastfeeding in the first week of life. This has been a big topic, and there are a lot of misconceptions about how babies need to feed in the first few days after they're born. So first things first, we don't have milk. So if you're a first-time mom, your milk does not come in for the first 3 days or so, even 3 to 4 days, depending on what kind of delivery you've had. If you've had Pitocin, if you've had a lot of IV fluids, if you've had surgery, an unmedicated delivery, there are a lot of factors that affect how quickly your milk comes in. And there's a lot of misunderstanding about babies' needs. So let's just start off with babies are born with something called brown fat. It's this fat that they have, it's subcutaneous brown fat, or adipose tissue, right? We don't have it, and babies are born with it, and it's what they sort of live off of until the milk comes in. Because the body knows how to work. If we were supposed to have milk for a baby immediately after birth, we would, but we don't. So it's just not how the brain works. It's not how, what's called lactogenesis, it's not how it works. So the impetus, the reason we make milk, the impetus, the trigger for our brain is once the baby is born and the placenta delivers off the uterine wall. That's called lactogenesis 2. It's the second phase of how we make milk. The first phase, actually, lactogenesis 1, is puberty. So when we go through puberty, most of us will develop breast tissue, right? We develop this, the glandular tissue to ultimately make milk. Some of us make more breast tissue than others. And a lot of that is adipose tissue. So the size of your breast, thankfully, does not have an effect on how much milk you make. Somebody once said to me that my breast couldn't make milk for an ant. And that wasn't an aunt, like a person, an A-U-N-T. It was for an A-N-T. And I was like this, listen, excuse me, but I'm actually breastfeeding my kid, and he is significantly above the age of a common breastfeeding baby in the United States. I'll just leave it at that. I breastfed my kids generally for longer than most people in the U.S. breastfeed their kids for. But I was certainly within the norm of human lactation, and most babies will self-wean, most children will self-wean at a certain age, and that's a whole other topic. So I'll just cliffhanger. How long did you breastfeed your babies, and does anybody know, I know several of you do know how long I breastfed my babies, and certainly my last baby. So what happens is we go through puberty, we develop glandular tissue, and then lactogenesis 2 happens when the placenta comes off the uterine wall, and the brain goes, oh my gosh, a baby was born, the placenta is delivered, it means I have to turn the factory on and actually get milk going. Lactogenesis 1, an analogy is that it's the groundwork, it's the foundation for the building. It's the foundation for the factory, right? So the structure is starting to become assembled. Lactogenesis 2 is, okay, we have this structure, we just haven't turned the power on yet. So once the placenta delivers, the brain goes, oh, let's turn the power on. And it takes a couple of days, once we turn the power on, for it to get into all of those ducts and for the milk to finally come in. Okay? So what we need to know about babies when they're born, regardless of the size of the baby, whether you have a 7-pound baby or you have a 10-pound baby, all babies' stomach capacity is about the same size. And so for the first 1 day, the first 24 hours of life, your baby's stomach capacity is 3 to 5 milliliters. And many people don't know how small that is. So I have some examples set up here. So this little glass bottle is a 10 milliliter bottle. This little guy is 10 milliliters. Your baby's stomach capacity is half of that, less than half actually, 3 to 5 mils is your baby's stomach capacity. And what I put in here, what I do need actually, this is an empty jar. I am not promoting any bottles. I'm not disparaging any bottle companies. There are lots of reasons why you might choose the bottle if you choose to give your baby a bottle, which one you would use. So this is not a conversation about what's good or bad. It might be a little bit.
It will be in a minute.
But it has nothing to do with the brands. Okay, so this is 10 mils, right? So your baby's stomach capacity in the first 24 hours is half of this. So your baby, this is a regular old bottle. And here's a 1 ounce, 2 ounce, 3 ounce, right? This is what you would normally feed a baby. So I'm going to pour half of this in. So that's about 3 mils. Did you see that? That's like nothing. It's about the size of a thimble, if you can see that. It doesn't even barely cover the bottom of this bottle. And then I'll do a couple more, and that's a little bit more than 5 mils, okay? So 5 mils. An ounce is 30 milliliters. 1 ounce is 30. Your baby's stomach capacity in the first 24 hours is 3 to 5 mils. An ounce is 30, 5 mils. So tiny. So all those family members that I know, everyone is concerned when a baby cries that it must be hungry. Feed the baby, feed the baby, feed the baby. Of course, you should always feed your baby. But there's a lot of misunderstanding. It's not necessarily due to hunger, but due to the baby's innate need to suck in the first, few days of life. The more the baby goes to the breast, the more you stimulate, and the more the factory says, oh gosh, we got a lot of rooms to fill up here. Let's get all the power in, right? So the more you feed your baby, and we recommend in the first 24 hours of life that you feed your baby ideally 10 times. Because we know if a baby gets 10 feedings in the first 24 hours, they're less likely to have high levels of bilirubin, which causes jaundice. And by the way, jaundice is a normal physiological event if it's after the first 24 hours. So that's the yellowing of the baby's skin. It starts from the top of the head and it goes to the toes. So we first start to see yellow like between the eyebrows and then kind of around the mouth, the whites of the eyes, and that happens after the first 24 hours. And the more we breastfeed a baby, the less that bilirubin, that number stays in a normal range. Bilirubin is an antioxidant. So all babies have a certain level of bilirubin. We just don't want it at an extreme level, which can be complicating. So your baby's stomach capacity in the first 24 hours is 3 to 5 milliliters. Itty bitty, teeny, teeny, tiny. A couple of drops at a time. So that colostrum that you're making, that you think you don't have any milk, because you don't, you have colostrum, is in drops, right? And so sometimes you can see it, sometimes you can't see it. But the baby is getting it if the baby goes to the breast. And we recommend feeding the baby every 2 hours during the day and every 3 hours at night. Then the baby goes to the second 24 hours, the second day of life. And that stomach capacity goes from 3 to 5 to 5 to 10 milliliters. Still, itty bitty teeny tiny, right? This bottle is 10 mils. So maybe by the end of the 48 hours, this baby might be taking in this much per feeding. And then you get into the third day, so now we're up to about 15 mils. That's a half an ounce. By day 4, now we're having a baby that's getting about an ounce per feeding. And miraculously, that's when your milk is starting to come in, right? For a first-time mom. Subsequent moms, second, third, fourth-time moms, your milk comes in a little bit sooner with each baby. So it's not surprising to us when we go see one of our moms that just had a third baby or a fourth baby, and we do the 24-hour visit, and they feel like their milk is coming in already. It's typical. So what we hear a lot when we go to the home visit here at the birth center, we do a visit with you. I'm a lactation consultant. I'm an IBCLC, as well as being a licensed midwife. I'm an international board certified lactation consultant. So it's the highest level you can be in lactation. Who knew there was that much training in lactation? But there is. As an IBCLC and as a midwife, we come and do a home visit with our families that had out-of-hospital births. We come see the baby 24 to 36 hours after the birth. And one of the things we do, in addition to being midwives and doing all the baby stuff and the testing that we do, we're also checking on breastfeeding. And we're making sure that the latch is good and the baby's going to the breast frequently enough and that the baby is stooling enough. So one indicator, it's very hard to tell if your baby's getting enough to eat, and everyone thinks the baby is not. Generally, family members think the baby must be hungry because it's crying so much. But most babies are getting enough, and the indicator is, since you can't measure colostrum, is output. We say input equals output. So if the baby is taking in enough colostrum, the baby will poop. The baby will also pee, but the urine is so scant. It's in such itty bitty amounts. It's very hard to see, especially if you use disposable diapers. But the poop, which is called meconium, that's the baby's first poops for those first few days of life, you're going to see the baby should have at least one poopy diaper in the first 24 hours. That indicates that output is okay. The second 24 hours, we see 2 poopy diapers. And the third 24 hours, right, third day of life, 3 poopy diapers. So 1 poop or diaper per day of life until the milk is in indicates that this baby's volume, what the baby's intaking, is enough. I pause there for a minute because there are some variations to that. If you have a breech baby that's born vaginally, they may not poop in the first 24 hours because when they're being born, all the poop gets squished out, kind of like a Play-Doh machine. And so they get all that meconium out, and they don't really poop in the first 24 hours. But that's an aside just for those, unfortunately, rare breech deliveries that we see, rare breech vaginal deliveries that we see. We might not expect those. We don't expect those babies to poop in the first 24 hours. But all vertex, head-down babies, vaginal deliveries, or C-section doesn't matter. And it doesn't matter how much the baby pooped. As soon as the baby's out, the poop that the baby has from the time it's born outside of your body to the next 24 hours exactly, whatever that baby poops, as long as it poops once, is all you need. So a lot of those babies will poop even before, if they have the baby here at the birth center, those babies will poop within the first 2 hours. That's the first 24 hours, right? So that's all the baby needs to do. What happens on day 2 and or day 3, and we talk a lot about this when we do our home visits, but this is something that's not talked a lot about in the hospital, I don't believe. Babies cry that second and or third day of life between 10 p.m. and 4 a.m. They just are screaming their heads off. And it's not because you're not making enough milk. It's not because they're hungry. It's not because they don't like the way you smell. It's not your deodorant. It's not your lotion. It's not anything you ate. It's not personal. We really personalize it as breastfeeding mothers. It's like the baby doesn't like me. He's crying. He's fussing. There's nothing I can do that puts him to rest. He goes to the breast. Suck, suck, suck. Bop, bop, bop. Arch, cry. Back to the breast. Bop, bop, bop. You know, they do this head bopping thing at the breast. Bop, bop, bop. Pull off. Rah! Go back to the breast. Rah! Arch and cry, and there's nothing that settles them down. That's night 2 and or night 3 between about 10 p.m. and 4 a.m. Typical, typical, typical. Often in the hospital, we hear a lot of the times that the baby is hungry. Moms are given a nipple shield at that point. They're offered formula because the mom's milk's not in yet. She's not making milk. Therefore, the baby's hungry. We even hear it out of hospital. Family members that are very concerned that the baby's crying. I told you don't have your milk yet. The baby is hungry. Not true, okay? As long as you're waking this baby and putting it to the breast, the baby is not hungry. It's just normal. It's gas. This baby has never been outside of your body, right? So it still wants to be in utero. It doesn't know how to find its own hand. It doesn't know how to self-soothe. Those things don't even take place until like week 12. 12 weeks of life. What's 7 times 12? 14. That's 84 days, right? So we're talking about 48, 2 days, 3 days old, right? These babies have no ability to self-soothe. Do not want to be sleeping separate from you. They want to be attached to your body. They want to be swaddled. They want to be bounced. They want to be shushed. It's that 5 S's thing, right? Swaddling, shushing, swaying, side-lying, and sucking. Those things all tend to calm a baby within the first 12 weeks of life. So it's not hunger, okay? So we do not want you to give a baby a bottle in the first 4 weeks of life. Now, some babies need to be fed in a different way because they're not going to the breast, and there are different ways to feed a baby. But for today's purposes, we're just talking about normal newborn behavior and baby's stomach capacity. So these bottles here, this is 1 ounce, right? Can you see the volume in this bottle? It goes to the first line, right? So that's 1 ounce versus that's about 5 cc's, right? I don't know if you guys can see the difference in the bottle. You can't even probably see that there's water in the bottom of this bottle versus this one. You can really see the volume. This is way too much volume for a baby in the first 3 days of life, right? Babies don't need to take 1 ounce per feeding. They just need about that much per feeding. And so when we look at that, this is a super tiny medicine dropper that is full, right? So, I mean, really, truly, it's just, you know, a few drops is all the baby needs, okay? So that's not very much that your baby is needing. So what we do with babies that are having a hard time going to the breast in the first couple of days of life is we rig like a 10 cc syringe and we attach a tube to it, and we can suck train a baby with our thumb. So whenever you put your finger in the baby's mouth to soothe them and to teach them how to suck properly, you always use your largest finger, either your thumb or your index finger, because the goal is that you get your baby's mouth to open really wide. Everybody intuitively wants to use their pinky, but the goal is big, wide open mouth. So you always want to use your thumb or your whichever index or your middle finger, whichever is more comfortable for you to use. And once you get the baby sucking properly, we put a little tube in there and we just syringe feed them. And that's a way to suck train a baby. And if I had a baby here, I would show you how to do that, but we don't have a live baby that needs to be suck trained today. But next time I do, I think I'll videotape it so you guys can see what that looks like and what that volume looks like and how to train a baby to go to the breast. The biggest mistake we make in the early days of breastfeeding is assuming we don't make enough milk and assuming the baby needs a bottle, and we do 1 ounce at a time, so we overfeed the baby. Plus, when we give a bottle, so I'll use this very popular brand, really good marketing skills, and so this is a really popular brand. I'll show you how quickly the milk comes out of a bottle, even when it says newborn nipple slow flow. They all say newborn nipple. I mean, all newborn nipples say newborn nipple. But they all say slow flow, low gas. They all say the same thing. It's all marketing. They all kind of come out pretty fast. So one indicator to see if the milk is coming out fast, because you remember at the breast, the baby has to work really hard. It has to pull to get that milk out. And it comes out in drips until the milk comes in. It does not flow quickly until the milk is in, and some women have what's called it like a forceful letdown. But we're talking about the initial first few days of life and why we don't want to give a bottle. The milk comes too fast. So this bottle, I don't know if you can see, right? So I have it upside down, nothing is dripping. But as soon as I apply, oh my gosh, as soon as I apply some pressure to that nipple, I don't know. Oh, I should have had colored water in here. Then you would have seen it. That would have been so good. But can you see how I can get, I mean, I'm just applying a little bit of pressure. And do you see how it's just pouring out? And there's just some compression there. Even just dripping out. Drips pretty quick. So, so when a baby goes to the nipple, right, it just sort of, when you compress it, it just sort of shoots out. And when a newborn baby is just getting that milk shot down like that, as soon as they compress it, it shoots out. They have to pull their tongue back. So it affects how they go to the breast. So the mechanism, the anatomy of a baby at the breast, normally just at the breast. So the tongue comes down, it comes over their gum line, it furls, makes like a scoopy thing, like that. And their lips flange out like a suction cup, right? And then that tongue comes all the way down, and the middle part of the tongue pushes up against the hard palate, and it creates a vacuum, and then the tongue sort of undulates. So you hear a lot about tongue ties, lip ties. Are we overdiagnosing them? It's amazing how many we see of what's called a posterior tongue tie. And many providers don't necessarily address a posterior tongue tie because it's the baby's tongue can extend, right? An anterior tongue tie or a classic tongue tie, that baby can't even extend its tongue. They can't do that. If they do that, it actually, there's that frenulum, little muscle under your tongue, thing right there. It's sometimes attached too close to the tip of your tongue, and then the baby can't extend. And it creates like a fork, like a heart-shaped tongue. They can't even get it over their gum line. They can't do that. So that's a classic anterior, very obvious tongue tie. A less obvious tongue tie, but still has a significant effect on breastfeeding, is called a posterior tongue tie. And that's when the baby's tongue the middle of the tongue can't lift. In the middle of the tongue with the posterior, when a baby cries, you'll see that it makes a bowl. So it can't, you can't see what I'm doing, but it can't push the middle of the tongue to the roof of the mouth. It can't do that mechanism. So, okay, so when a baby goes to the breast initially, the tongue has to extend, it has to furl, the middle of the tongue presses up against the roof of the mouth, and the lips flange up like a suction cup. When a baby goes to the breast and the milk comes shooting out in that fashion like I just showed you, it comes too fast, so the baby is very smart and pulls the tongue back to block the flow of the milk. And then it's passively just mashing its gums, mashing the gums and keeping the tongue back so it doesn't choke on the flow of milk. So then we switch this baby to the breast and it doesn't know how to use its tongue properly. And now we have this issue of not a good latch, damage to the breasts, and it complicates the issue. So that's why we do not recommend bottle feeding. I made a mess. Bottle feeding a baby in the first 4 weeks of life. If you do have a baby with a breastfeeding problem, go find a lactation consultant, an IBCLC. Yes, you may have to pay out of pocket for that, but I'm telling you, it is definitely worth your time and your effort to save your breastfeeding relationship. Many people don't do that. And then by day 4, they're giving baby bottles. Then by 2 weeks, the baby is just exclusively bottle fed and we might be pumping. And then I can tell you by 6 to 8 weeks, if you're just exclusively pumping, most likely your supply is going to start to tank. You're not meeting the baby's needs. By 12 weeks, we have a baby that's bottle fed with some breast milk, some formula, and then ultimately we aren't even giving the baby breast milk. It's a big problem here in the US for sure. So you want to see a lactation consultant right away. So the big takeaways from today's Facebook Live is your baby's stomach capacity is so tiny, you guys. 3 to 5 milliliters in the first 24 hours, 5 to 10 in the second day of life, 10 to 15 in the third day of life. So teeny, 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 tiny. All babies, most babies will cry on the second and or third day of life from 10 p.m. to 4 a.m. Everybody's crying. It's really stressful. Everybody wants to overfeed this baby with formula. That is not the solution. All babies do it. There's nothing wrong. You're not doing anything wrong. The baby loves you. They are just born to bond to you. You're doing okay. You just need some help. Swaddle that baby, shush that baby, bounce that baby, rock that baby. Really just hold on tight and try to get through the night, but really resist giving the baby a bottle, assuming the baby is going to the breast every 2 to 3 hours. Feed your baby every 2 hours during the day, every 3 hours at night. Wake those babies up, because the more you feed them, the more calories they get, then the more they are likely to stay energized and able to suck, right? And so then we're going to decrease the level of jaundice. A baby that doesn't feed well, that bilirubin starts to climb because they're not pooping. The bilirubin starts to climb. They get more and more jaundice, which causes more lethargic behavior, less likely to wake up, more dehydration. So then we get into this spiral of sleepy baby is a dehydrated baby, is a highly jaundiced baby, is a baby that's, having some difficulty, then has to be readmitted to the hospital on Billy Lights and formula. So we really want to just wake this baby every 2 to 3 hours during the day. The baby needs to suck for about 10 to 15 minutes nutritively, not pacifying, not quick, rapid, but pull, swallow, rest, fall asleep, cry. They forgot what they were doing. Reteach them. So it's that deep, big pulling, about 10 to 15 minutes of that every 2 hours during the day, 3 hours at night. If you do that for the first few days, your milk will come in. your supply will be adequate, and your baby will thrive. There are techniques on how to get the baby on deeply. That's a whole other issue that's difficult to show, but the next time we do a consult with a mom and a baby, I'll ask their permission if we can videotape it so you can see how we solve breastfeeding problems in those first few days. And I'm going to just touch on one interesting fact. The impetus, like I said earlier, for you to go into lactogenesis 2 is the delivery of the placenta. So I just pose a question to people that are supportive of consuming the placenta postpartum. I have some doubts about placentophagy, that's what that's called, or dehydrating and consuming your placenta as a supplement after the baby's born. I am definitely in the minority of out-of-hospital birthers who is not super into eating the placenta after the baby is born. But one thing I'm curious to ask those that encourage placentophagy or consuming the placenta is if the impetus to make milk is the delivery of the placenta, and we know that if a little fragment of the placenta is retained, which we never want part of the placenta to be retained on the uterus after delivery, it can cause postpartum hemorrhage, uterine infection, and a decrease in milk supply. My question is, how can consuming the placenta postpartum increase milk? It's not logical. But that is a subject for another day. That will maybe encourage a lot of chatter because, there's a lot of talk about that situation. So we'll talk about that another day. So 3 to 5 milliliters is your baby's stomach capacity in the first 24 hours. Second 24 hours, 5 to 10. Third day of life, 10 to 15. 1 ounce is equal to 30 milliliters. Your baby doesn't hate you. Your deodorant is fine. Your body lotion is fine. Your shampoo is fine. Whatever you ate for dinner on the second and or third night is fine. All babies cry second, third night between 10 p.m. and 4 a.m. You don't make milk right away. You just have colostrum. You're not going to be able to see it probably. It's itty bitty teeny tiny little drops. So all those people that are telling you you're not making milk, right, you're not making milk, and that's normal. Babies have brown fat that they can survive on. We expect babies to lose 10% of their birth weight by day 2. By the time you're discharged from this hospital, the baby is going to have lost weight. Normal, normal, normal. Especially if you've been induced and you've had multiple bags of IV fluids. If you've had Pitocin, it delays the onset of milk production. If you had a surgical procedure, all of that can affect your onset of milk. And it can also overinflate the weight of the baby. We do know that studies show that mothers that have received multiple bags of IV fluids in labor, their babies tend to lose more than 10% of their birth weight by the time they're discharged from the hospital. That is not necessarily a bad thing. That's sort of a general thing to say. So we expect 10% of the baby's birth weight. That is normal. We don't expect your baby to regain its birth weight until 2 weeks of life. Most regain by 1 week, but it's normal to not regain by 2 weeks of life. And normal weight gain once your milk is in is 4 to 7 ounces per week once your milk is in. Okay? If you have questions or concerns, please ask them here below this Facebook Live. Follow us on Instagram, SCV Birth Center on Instagram. This is on YouTube. Engage in the conversation. Let's help our fellow breastfeeding people continue to breastfeed, support our breastfeeding community. We support any way that you feed your baby. If you choose to bottle feed and that's what's right for you, we support that. If you choose to do formula, you have some reasons to do that, we support that. But we want to make sure that you're not defaulting to bottles and formula because you didn't get the right support. We're all about informed decision making. If you want to bottle feed your baby and you're informed about it, right on, do that thing. But if you really want to breastfeed and you're having trouble, you must reach out and get help. And yes, you may have to pay for that out of pocket, but some insurance companies will reimburse a lactation consultant's fees. They are worth every penny. I promise you, it will save your breastfeeding career. And then you'll go on to breastfeed for a very long time. The American Academy of Pediatrics recommends breastfeeding at least until the age of 1, at least until the age of 1. The World Health Organization recommends breastfeeding at least until the age of 2. Natural weaning age, for a human baby is between the ages of 4 and 7 years old, not months. Blows people's minds. So there you go. Take that home with you and let's have a conversation. Okay, thanks for joining us, everyone, and we'll see you next week. Bye.